Live from the Washington, D.C. area, it's the Inside Scoop. All the news that our viewers want to know. Now, here's the host.
Welcome to Inside Scoop. I'm your host, Catherine Reed. And tonight we're going to be talking about health care in Virginia. And joining me will be Senator George Barker, who has a long, extensive background in health care here in Virginia. And he has also been a senator since 2007. And so he's going to walk us through the topics that are on everyone's mind right now. Welcome, Senator Barker.
Thank you very much, Catherine. My pleasure to be here with you.
So you have not only your education is in public health and public health management, but for 30 years you have worked in the healthcare field here, specifically in Northern Virginia, and you also serve in the Senate, which makes you uniquely qualified to talk about many of the issues that are on people's minds today.
Yes.
So tonight we're going to be talking about federally qualified health centers and the Affordable Care Act and the Children's Health Insurance Program, and we're going to be talking about Medicaid expansion. So I want everyone to stay tuned because it's an hour-long show, and we're going to pack a lot of information in there, but let's start with federally qualified health centers. You know, how many do we have in Northern Virginia? Who do those centers serve? And how are they funded?
Federally qualified health centers are established under federal law. Actually, the first health center in the country was set up in Massachusetts in the mid-1960s, quickly followed by one down in the Delta area in northern Mississippi. And so they then became sort of the springboard for establishing similar types of programs across the country. It was part of the war on poverty during the Johnson administration when this got established. And there are a large number of health centers in every state across the country. In Northern Virginia, we have 3. In Virginia, we have over 20 federally qualified health centers. They get some federal money to assist them, but they also have a lot of requirements. The federally qualified health centers are required to take everybody, but they do take a lot of people who have health insurance, so it's not simply for those who are uninsured, even though you may see 30 or 40% of the patients at many of the health centers being uninsured. So they get people on Medicare, people on private health insurance, people on Medicaid, people on VA services, so it's veterans covered there. So it's a wide variety of people who use those programs. And you get different services offered in different health centers around the country and around the 3 we have in Northern Virginia. They do provide a lot of the services to people who otherwise would have difficulty gaining access to care other than going to the emergency department.
Which is not what we want.
Which is not what is good. Certainly not good health care and not good for the individual in terms of comprehensive care and continuing care and dealing with things that sort of what's hurting me today, but not necessarily what do I need to do tomorrow. But also what you have in that situation is it affects all of us. Because when those people are uninsured and aren't covered, picked up through a community health center, go to the emergency department, those services are paid for, but they're paid for by you and me and
through
those
the premiums
of us who have
pay.
Premiums that we pay.
Right.
So we're already paying for those services. It's much more efficient to get them care in the proper setting, in an outpatient setting such as a community health center. We also do have a couple of free clinics in Northern Virginia operating. They have smaller volumes in aggregate, although one of the free clinics in Northern Virginia, the one in Arlington, is a very large free clinic. And so we have both free clinics operating and federally qualified health centers. So there are a lot of those types of programs around, and they provide, as I said, a wide variety of different services.
And what about like just your basic Department of Health that provide things like, for instance, vaccinations? I mean, there's lots of different ways that people can access free health care or more affordable health care through the public health system here in Virginia. But nevertheless, it's still a cobbled together network, and maybe not all people even know how to find these clinics. I mean, for Northern Virginia, we've got 3.
Yeah, part of what has been happening over the last 10 or 15 years anyway is that the state health department and the local health departments have been getting out of the business of providing direct care services. So they used to have, a number of them had various types of programs where they provided the care directly to people. And in many instances, they have discontinued those. And others, they've scaled them back as free clinics and federally qualified health centers and other programs step forward. Fairfax County is different than most health departments around the Commonwealth, in that Fairfax County has under contract, has a contract to, right now it's Inova, previously it was a corporation out of California, to operate 3 facilities providing services to uninsured people below 200% of poverty, and theirs is specifically targeted at the adult population. So they have one in the Route 1 part of Fairfax County, they have another one in the Bailey's Crosswoods area, and one in the Reston area that are providing those services. So they are sort of the anomaly by having it, and part of the reason that got established in Fairfax County, and it's been over 30 years now that they've been operating that way, was they did it long before there were any federally qualified health centers and before there were any large free clinics in Northern Virginia. So Fairfax County stepped forward in the mid-1980s to provide that service and continues to fund that service. I mean, they don't provide it directly, but they continue to fund the service provided in those 3 centers.
Is that a good model? I mean, is that how do you see this going forward as far as optimally, since we've got free clinics and federally qualified health centers, and we've got Fairfax County doing their own thing? I mean, there's over 1 million people. There's 1.1 million people. That's a lot of people to take care of. But going forward, is there a better model? Do you see a model emerging out of all of that?
Well, I think what's happening here in Northern Virginia mirrors to some extent what happens across the country. Things evolve over time, and those programs that are doing a good job and are successful, they by and large will continue. And so to the extent that we have strong programs, particularly in Arlington with both their adult Arlington Free Clinic and their pediatric program that they operate there, they've had that model for 25 years. So it's been something that got set up a long time ago and has been successful, so they're going to stay with that as long as it's largely successful. Fairfax County, as I said, predated all the federally qualified health centers in Northern Virginia, and virtually everything on the free clinic side in terms of significant volume. And they clearly are continuing to provide services and meeting needs of a lot of individuals. So they will continue that program for the foreseeable future. They may evolve it over time, and they are already working with one of the FQHCs, one of the federally qualified health centers, the neighborhood health services for some services that the county is funding that way. But right now, they have not changed from the model that they've had over 30 years. And then Loudoun County, Prince William County, and Alexandria developed services that became federally qualified health centers. The first was in Alexandria, and then the other 2 emerged simultaneously, roughly in Loudoun and Prince William County.
And that was like 5 years ago?
No, actually the one in Alexandria started and got funded in 2002.
Right.
So it's been over 15 years now.
For neighborhood health.
What's now neighborhood health started out at Alexandria Neighborhood Health Services.
And then HealthWorks?
HealthWorks, which deals with covers Loudoun County and the Herndon area in Fairfax County. That one got organized. What happened was after we got the approval for the one in Alexandria, and I helped them a lot with that application, then people in both Loudoun and Prince William said, well, if they can do it in Alexandria, we want to try to do the same thing. And so both Prince William and Loudoun came forward about the same time, shortly after the program in Alexandria was approved, to establish their own community groups, and they began working on things. Both of them opened up services on a limited scale prior to being a federally qualified health center.
Right.
And then they were sort of, barely getting by and staying afloat. Sort of like, are you sure there's going to be a paycheck on Friday type of thing in many instances. But then in early 2009, they both got approval as part of the stimulus package after the Obama administration came in and was trying to address both critical needs across the country, but also to stimulate the economy, and this was a way to do both of those types of things. It's been at the federal level a very bipartisan support for the federally qualified health centers, and President Bush, the second President Bush, George W. Bush, put a lot of money into expanding the number of health centers across the country, and that was when the Alexandria one first got approval, and then it was when the Obama administration came in, both the Loudoun, which is now HealthWorks, and the Greater Prince William Community Health Center got funded at that time.
So going forward, because you were saying, we're assuming that we're going to be serving more and more people. So how do you scale these organizations to serve more and more people? I mean, is there going to be more federal funding? Where's the money?
Well, it depends on how things go. The more people get private health insurance, or if we were to expand Medicaid, if they get coverage through Medicaid expansion, many of those people who may be traveling some distance to get to one of the federally qualified health centers now, because they're more affordable than going in just paying privately to an individual doctor. Many of them may choose doctors closer to where they live. That's certainly been the experience in some states that have expanded Medicaid, for example. And so you may actually see some reduction over time as people have more options that are readily available and affordable to them.
And do you think the announcement today that CVS might be buying Aetna could impact the delivery of healthcare services more locally?
Who knows?
I mean, it's an interesting idea,
it's
isn't
an
it?
interesting idea, and CVS is certainly doing it, playing with a lot of things, such as having small clinics within their facilities. They're also doing a number of different types of things to address some of the opioid issues and other types of things. So, they're being creative and thinking ahead in terms of some of these types of things, and we'll see what happens there. So
well, like I said, I think it would be kind of the first model of its kind. A pharmacy moving into healthcare directly, and I don't know whether that's a good thing or a bad thing, but certainly there's a lot of CVS's close to where people live, and it would certainly be easier to get there for a lot of people.
Actually, the CVS is one of several entities like that operates pharmacies, but also does a lot of the insurance side of things through pharmacy benefit manager programs. And so this is not something that's totally foreign and new to them. So.
Right, they're just expanding basically what they have already done, which I totally understand, because from what I understood is that Amazon is going to get into the pharmacy business. So part of that is something else we need to look at is as other businesses get into the healthcare field, like Amazon getting into the pharmacy business, that we need to be a little bit more concerned about how we are going to, or how they are going to replace their revenue. So I think that announcement today and the fact that that's a possibility is interesting. I think it's very interesting, to your point, that with Medicaid expansion or a greater availability of health insurance, that we might end up having less demand maybe than we've had so far.
For some of those services, because we have fewer people who are uninsured.
Right. So one of the things, and obviously we're going to talk about Medicaid expansion in one of the segments of the show and who that's going to cover, and we're also going to talk about, and you mentioned it briefly, the services targeted at adults versus children, because there is a CHIP program here in Virginia. It's called Famous here, and we're going to be talking about that actually in our next segment. So please, after this break, come back. We're going to be talking with Senator George Barker about the Children's Health Insurance Program, what they're talking about as part of this tax bill that everyone's talking about, and how that's going to impact health care and health insurance here in Virginia.
You made your house a reality. Homeschooling yourself on loans, color-coding listings, and flushing every toilet in a 20-mile radius. If you can ace house hunting, you can do it for retirement. Get on track with tips at aceyourretirement.org.
Here's to the things that can keep us safe. Those we use all the time with hardly a thought. Those that are silently standing by to save our lives. And now, those that we carry with us everywhere we go. Many mobile devices will now bring you wireless emergency alerts, real-time information directly from local sources you know and trust. With the unique sound and vibration, you'll be in the know.
Listen, I realize that I'm not perfect, but it all really started to change because you judge me for having a problem. No one is going to know that I need help. I need help. I know that no one is going to judge me for having a problem. I realize that I'm not perfect, but it all really started to change because you listen.
Family.
Whether it's a short trip or a long haul.
Estimated time, 47 hours.
They will beg.
You're hungry? I'm happy to provide.
They will plead.
Deep fried butter on a stick.
But whatever you do, don't wimp out.
Now you're talking.
Make them buckle up.
He can't hurt.
Remember, safety first. Cheese curls second.
Are you orange?
We're back to the Inside Scoop. Here again, your hosts.
Welcome back to Inside Scoop. Tonight we're talking about health care in Virginia with Virginia Senator George Barker. Thank you so much for being here.
Certainly.
We have a call from Sheila in Herndon who's asking a question about CHIP, the Children's Health Insurance Program. That's obviously been talked about a lot in the media because there is an extension at stake. It was supposed to have been decided in October. It was supposed to have been decided in Thanksgiving. It's supposed to be decided by Friday of this week because there's a letter that was going to go out to families who, in Virginia, it's called FAMOUS, the CHIP insurance program here. Sheila would like to know how the tax bill that was just passed in the Senate and then the House, is that going to impact this extension of CHIP funding?
No, the tax bill won't impact the extension of CHIP funding. CHIP is a program, Children's Health Insurance Plan program, that was set up actually over 20 years ago, just about 20 years ago. And it was done, we often think now of healthcare as one of these issues where there's a significant partisan divide on it. Historically, that's not been the case. As I pointed out earlier, federally qualified health centers have always been strongly supported by both Democrats and Republicans. And the CHIP program was developed by Senator Orrin Hatch, a conservative Republican from Utah, and Senator Ted Kennedy, a liberal Democrat from Massachusetts. And they partnered together to get that legislation through in the mid-1990s. It was targeting a specific segment of the population because most states had Medicaid programs that covered at least children, not necessarily adults, but at least children below 133% of poverty. But various studies were showing that there were still a lot of children and pregnant women who didn't have health insurance coverage who were a little bit above that 133%. So that program targets specifically those between 133% and 200% of the poverty level. For which, a family of 4 would take you basically from between $27,000 and $40,000 in income per year. And a lot of people in that income category have enough money to be able to sort of meet most of their daily needs, but not to be able to afford private health insurance at a family rate level now. So a lot of those people were uninsured, and so they established that program. It has been operating great all across the country, for over 2 decades now. It's up for reauthorization, and partly because of everything else that's been going on in Congress and the failure to act on a number of things, they have not finalized it. So the expectation is that there will be some extension of it, either by reauthorizing it officially in the next couple of weeks, or by doing another extension for a short period of time while they get around to it. But if that were not to be done, then we would be running out of money once we get past the new year in Virginia and in many other states that don't have enough money to be able to continue the program. And there would be both pregnant women and children between 133 and 200% of poverty who would be affected.
Yeah, and I think the article that I saw that was published today said that it'd be about 68,000 children and 1,000 pregnant women would be affected. And so, previously they had said that a letter was going to go out on December 1st, and it didn't, because now they're saying that they hope that this reauthorization will happen on Friday. But I think we're also talking about a possible government shutdown, too. So I don't know, it's hard to tell whether anything's getting done in Congress or whether any of us should count on the fact that any of these things are actually going to be done on any schedule.
Well, schedule is not necessarily what the way that things often operate there. So
because it's been pushed back and pushed back
right,
and pushed back.
It does get pushed back a good bit. But what you also do frequently get is when you bump up to some deadline where there's something major that's going to happen if you don't act, they may not take the final action on it, but often what they do is then they'll pass a short-term extension for 2 months, whatever the time period is, which is how we got to where we are as it relates to the government shutdown and the budget for this fiscal year.
Right. So I know that Senator Mark Warner was tweeting earlier today with the hashtag #ExtendChip. So if people are interested in following along on this discussion on Twitter, #ExtendChip is a hashtag that apparently some legislators and lawmakers are using. Let's talk a little bit specifically about FAMOUS. People can actually find information, I believe, at dmass.va.gov about the program. So you might be hearing about CHIP in the news, but in Virginia, FAMOUS, F-A-M-I-S,
right,
stands for Family Access to Medical Insurance Services. How about that? So Famous in Virginia is our CHIP program, and again, serving maybe 68,000 children, 1,000 pregnant women. And so what could Virginia do? You're a state senator, you know, there's reauthorization of this act, but what about funds from Virginia? I mean, is it possible to keep the program alive if we're not going to get money, that the state itself could somehow?
It would be an extraordinary burden that is totally unplanned for right now for us to pick it up for any period of time. Obviously, in a short-term situation, you know, we might be able to do some things, but long-term, we don't have the resources right now within our existing budget to be able to do that.
And we have kind of a biennial budget, right? So it's every 2-year process?
We have a two-year budget,
right?
But we develop a 2-year budget and adopt it, which we will do in March of 2018 for the period from July 2018 through June of 2020.
So about the most we could hope for, if it's not reauthorized and we don't get federal funds, is that you could possibly put something in the budget for the next 2 years if the state were going to try to make up the difference. But even that wouldn't kick in until July.
That wouldn't kick in until July. Now, we also will make adjustments to the existing 2-year budget when we meet in January, February, and March of this year. So we could address some of it through that, but you'd have to have the resources to be able to do it, and it's not clear that we will have such resources at this particular time to be able to do that. And I think that is a highly popular program across the country. It has a long history of being supported by Republicans and Democrats, so it's not one of those partisan types of issues that should be, you think would be more likely to be holding things up. I think it's just sort of them working through the process in Congress to be able to get the action to implement it.
You know, and it was interesting too in this article they were talking about, and maybe it was the Richmond Times-Dispatch or the News Leader, I can't remember, but the paper published a profile of this family that has 3 children, and one of them has medical needs specifically and has a Medicaid waiver. But because of the change in their employment, and this is what happens to people, you change jobs or you lose your job and suddenly you don't have employer-funded health insurance. And so what are your choices if you have a family with children? And so her son broke his arm in 2 places and needed surgery. And she was talking about the fact that without Famous, they would be just, you know, $25,000 in debt for the medical costs for taking care of this child. And so the working poor, and there's probably some other way that you could talk about people who are working, some of them 2 jobs or both parents working, but simply cannot afford or qualify for marketplace insurance. This is at least one way to cover these children. I think a lot of people don't have in their minds, which is why I think this profile was important, of who these people are.
Right.
They're not indigent people. They're not homeless people necessarily. A lot of them are people in your community who are working hard.
Right.
But health insurance has gotten to be this enormous struggle in this country. Where to find it, how to get it, how to access it, can you get insurance, not get insurance? So Famous to me is really about covering kids whose parents are in a situation for a variety of different reasons, but not necessarily because they are indigent or homeless or unemployed.
Right, and Famous is, I said, covers those within 133 to 200% of the poverty level, which is basically the 27 to 40,000 for a family of 4. So they are not at the very bottom of the income scale, but don't have the resources to necessarily be able to, on their own, to be able to afford coverage. It has helped tremendously with a lot of families over time in terms of being able to provide coverage for the children. And in many instances, those children get covered through Famous, but the parents still don't have health insurance. And so they sort of have to fend for on their own a little bit there. Yeah. Sometimes, the parents may be able to enroll through the Affordable Care Act in the marketplace to be able to get insurance and have it be cost less than if they had to go through a family plan. So sometimes you have a little bit of the parents being enrolled one place and the children another. But one of the critical things as it relates to it is you talk about most of the people covered by Famous are children. There is a smaller number of pregnant women. But the pregnant women, there are a lot of different pregnant women who move through in a year or 2 period.
Right, because it only lasts 9 months. Thank goodness for that.
Yes.
Yeah, 9 months. Oh, that's good.
And many of them don't get covered until they're 3 or 4 months into the pregnancy. So there actually are a lot of pregnant women who get covered. In Virginia, 1/3 of all births are to women whose births are covered either through Medicaid or through the Famous program. I was at a conference recently with legislators from 8 states, all in the larger South area, from Maryland through Oklahoma. And we were the only state where less than half of the pregnant women who delivered were covered through the Medicaid or FAMOUS program, the CHIP program. So we have the majority, 2/3 of women in Virginia have private insurance when they deliver. In many other states, the majority of women don't have private insurance when they're pregnant.
Right. So I know that you meet with other legislators from other states, and you have not just a focus on Virginia, but where we fall in 50 states with benefits that we provide as a state. I've heard the term stingy thrown around. Maybe that's not accurate, but what would you say as far as in the greater 50 states, how Virginia's doing in providing health services, health coverages, and programs for people who need it?
What I can tell you is that our Medicaid program is consistently recognized as one of the best and most efficient Medicaid programs in the entire country. So we provide great coverage, we provide great services. We've been very inventive and creative and out front, moving to managed care plan approaches on things, being able to change the incentives for people so that people are incentivized to do the right things rather than the wrong things. And a tremendous management of money. We actually have the lowest rate of nursing home utilization for elderly population of any state in the country, because we do more things to keep people out of nursings.
Keep them at home.
So keep them at home or supportive services within the community. So there are a lot of very good things. But you are correct in that we, to put it maybe a little less harshly, we are frugal. So
you've got good services, but maybe not for a large number of people.
Well, it's not so much the large number of people, because we do have less people who qualify because our economy is much better than many other states. But we don't pay well for the services we have. And so when someone who's on Medicaid or the FAMOUS program goes to a doctor or to the hospital, that doctor or hospital is reimbursed much less than what it costs them. So they're losing money on every patient they take. They're just doing it as a part of their mission and public service there, because we don't pay them what it costs. Even the nursing homes, most of them are paid less than what it costs, although we do better there because there aren't a whole lot of private paying patients in most nursing homes in most parts of Virginia to be able to support them otherwise.
Well, so that's kind of good news. I'm glad to hear that we're doing so well. When we come back from this break, we're going to be talking about the Affordable Care Act with Senator George Barker. Some of you may know it by its other name, which is Obamacare. And there is a deadline looming. That deadline is December 15th. So please join us, and Senator Barker is going to fill us in on what we need to know.
The papas out there, let's stop what we're doing and take a moment to be with our kids. They can be loud moments, goofy moments, dorky moments. It doesn't really matter. Every time dads take a moment to be with their kids, it's pretty momentous. So let's all take a moment to make a moment today.
Hey, did you know that 2.4 million loving cats and dogs in shelters and rescues need our help to find a home? Go to theshelterpetproject.org and search your local shelters and rescues. Go for a cuddle with your next best friend. Adopt.
Okay, so we drowned the fire, stirred it, drowned it again, and now just feel if it's cold.
Yeah.
Cool.
Smokey just gave me a bear hug.
I know. I already posted it.
We cannot be bystanders.
We can stop to make sure someone is okay.
We can warn someone when their drink isn't safe.
And disrupt the situation.
We can.
Get someone the cab.
Or walk them home safely.
We can make campuses safer for our friends.
Our roommates.
Our classmates. Our fellow human beings.
We cannot be bystanders.
We can. Intervene.
It's on us.
All of us.
Learn how and take the pledge at itsonus.org.
When it comes to saving money,
What?
don't act like a baby.
Oh, it's like they're having their own little meeting.
This is so humiliating.
Be the boss.
I'm the boss.
What the?
Power nap.
You were saying.
And make a budget.
Let's get to work.
Need a little help?
Stacy, read back the notes.
I can't read.
What's it say?
Create a personalized savings plan and get other tools and tips.
We can share.
You obviously didn't go to business school.
At feedthepig.org.
We're back to the Inside Scoop. Here again, your host.
Welcome back to Inside Scoop. I'm your host, Catherine Reed. Tonight we're talking about health care in Virginia, and joining me is Senator George Barker. Thank you so much for being here.
Thank you.
So, we're going to switch gears and talk a little bit about the ACA, also known as the Affordable Care Act, also known as Obamacare, which polling shows many people are not aware are the same things, right? So people have misconceptions about the ACA, and now we have a tax bill that could possibly impact that. So help us walk through how the ACA was developed, why it was developed. You can talk about the individual mandate and how the removal of that might impact how all of this is going to change.
Well, the Affordable Care Act, as how I generally refer to it, was developed shortly after President Obama came into office.
That was his signature legislation.
That was his signature legislation, that plus the stimulus package that was introduced right when he first came in, when we were losing 7 to 800,000 jobs a month, and we had to turn that around rather quickly, or we would be in much bigger trouble by now. But it was Congress debated legislation throughout 2009, and then in early 2010 that legislation passed. It was really modeled on two things. One was that back in the 1993 and 1994, when President Clinton had proposed a major health care plan, the Republicans felt that he had gone too far in some areas, and they developed their own plan, and their own plan was amazingly similar to what later got adopted as the Affordable Care Act. So it actually came mostly out of a Republican approach to things that relied upon utilization of existing private health insurance plans, and only had the government stepping in where necessary to be able to provide coverage for people who could afford very little. The other major driver in terms of the development of the Affordable Care Act was the plan that was passed in Massachusetts just a few years before the Affordable Care Act considerations in 2009 and 10, when Mitt Romney, who later ran as the Republican nominee for president, developed a plan. So it really had, the Affordable Care Act really had its parentage in Republican initiatives in both the 90s and in the early 2000s. It was targeted specifically at a variety of different issues. One was the large number of people, and to a certain extent a growing number of people who lacked health insurance coverage. And at the time we were faced with a situation where over 16% of the entire population of the U.S., about 1 in every 6 people, was uninsured. That creates a lot of problems, particularly when we expect that they will get care when they really need it. But then all that care gets passed on to those people who, through premiums and other types of things, to people who do have health insurance coverage. They also wanted to have it address the cost. In the U.S., we are spending about almost 20% of our gross domestic product on health care.
So it was really,
no other country spends more than about 13%.
It was an economic decision. I mean, Obama campaigned on that because we were spending so much, had such poor outcomes. We were spending so much more than other developed countries. Right. And he felt like we were going to go bankrupt, that it was unsustainable. The system the way it was simply economically unsustainable. Right. And
the Affordable Care Act has produced pretty much every result that it set out to address. It has actually decreased the deficit because it was fully funded, and actually the expenditures have been less than what had been projected, and the revenues that supported them have been more than what had been projected. So it is we also began to see for the first time in many, many decades a situation where we were not having healthcare expenditures nationally rising at a faster rate than the income across the country. So whereas for years healthcare expenditures kept going up and taking a larger share of the total total gross domestic product in the U.S., that no longer is happening. So we're seeing cost controls, we're seeing more people insured. In many, many states now, it's less than 10% of the population is uninsured. We're down to about 10% in Virginia, but we've been slightly higher because we do not have the Medicaid expansion program that the majority of other states have.
But the individual mandate, actually it was the Supreme Court who actually ruled on the constitutionality of the individual mandate was about, because insurance is about having a pool of people, some of whom are healthier and use fewer or no services, to support the ones that are older and sicker and use more of the services. So that whole concept that we would get young 20-somethings who did not have employer-based health insurance even as an option would be paying in because they're a young, healthy population. What is going to happen to that if they change that stipulation?
Well, one of the tenets is exactly as you said. To make the system work, you have to be able to provide care to people who have chronic conditions, have pre-existing conditions, who are not as healthy as other people and need services. To make that work, without having premiums that are just through the roof, you have to have that pool that includes healthier people in there. And so it is critical that you have the healthier people as part of that population. What is in the Senate version, it was not in the House version, but it was in the Senate version of the tax cut bill that just recently passed the Senate. They removed the penalty for not having a health insurance coverage. So the message that's being sent, if that were to stay in place, is that all you young people who are pretty healthy right now don't get insurance. Wait till you get sick, and then we have to cover your pre-existing condition. So what it does is it provides a strong disincentive for people to do the right thing to get the coverage. And what it does, it makes the coverage that's out there much more expensive and makes it prohibitive in some instances for people to be able to afford it. So on both ends, it would actually decrease the number of people who would be insured. To calculate, the estimate that I've seen on that is 13 million people would lose health insurance coverage as a result of that.
Yeah, and that's, so I have two kids who get their health insurance from the ACA, and they took it very seriously. And I think a lot of young people did. Young people, because of the jobs prospect and the economy, and it's not that the economy in Virginia isn't strong, it is, but a lot of people have part-time employment. A lot of people are working 2 or 3 jobs part-time, and therefore they are not offered health insurance through any other place except the marketplace. If the ACA wasn't there, they would simply be uninsured, showing up at the emergency room when they had a car accident or broke their arm or got really sick. So I think the Affordable Care Act actually did something in the years since it was introduced to help young people understand, and especially because many of them are subsidized, that they can afford health insurance. And my kids don't use it, so they're just paying into the system, and other people use it because they don't get sick. And that's the whole idea. And I'm not sure if this remains in the Senate version of the tax bill, whether this is going to fall apart. Do you see that seriously it could unravel?
Well, I mean, we've already seen some indication of the insurance mandate and the exchanges unraveling. Because what's happened over just the last few months during the Trump administration has been that the threat of withholding some of the monies that are due to the insurance companies to be able to support the people who are at the lower end of the income scale and may have some significant health issues has led some of the insurance plans that previously were participating to pull out of it.
Yeah, we had that situation in Virginia. They pulled out and they came back.
Well, they pulled out and they were
coaxed back?
The arms were twisted to be able to get them back in, but there's no guarantee that would continue next year.
Yeah.
And particularly if there's not some resolution at the federal level, that they're not going to certainly start losing significant amounts of money. And that is a legitimate concern, and you've got to realize that if you want a private market system, which is what the Republicans in the 90s and early 2000s came up with, then you have to understand that from a private market perspective, it's not in the interest of the insurance companies to intentionally take on major losses.
Absolutely not. That's not a business model that works for anybody.
Right.
And I sort of feel like, I always felt that the ACA was a march towards something that we need, which is to separate health insurance from employment. I don't know why any employer would want to be in the business of providing health insurance for their employees if their employees could choose their own, pay for their own, and it's portable benefits that you take with you. So I would have thought that the business community would have embraced this idea that they could get out of the business of subsidizing and providing health care plans for their employees, but that is not how this has been perceived at all.
Well, and actually, the part of the structure that was set up with the Affordable Care Act was to have the employers providing the coverage. So what you get is that, I think for employers over 50, they are required to provide coverage. that means that there are still some people who may not get coverage because they're less than 50 people within that business. But what has happened, particularly in Massachusetts, where they did this first, once the program got up and operating, everybody expected that they would get health care coverage. Every business knew that it was going to be difficult to recruit people to come work for you if you didn't provide health insurance coverage, because they all expected to have it. And so it just changed the whole psychology from both the employee and the employer side to be inclusive. One of the other issues that we have with the Affordable Care Act is, even though there's a requirement for large employers to provide coverage, that doesn't mean they have to provide it for the employee's family. So sometimes the employee will be covered, but the employee's children or spouse or other people within the family are not covered. So there are clearly still some gaps.
And I think after 2008, after the Great Recession, there were a lot of people, after they laid off employees, who brought them back part-time. I mean, I think that a lot of companies have trimmed their benefits bill by simply hiring more part-time employees that they don't have to cover because they don't meet the full-time requirement.
Well, there clearly are some that do that, and then, less than 30 hours, you don't have to provide health insurance coverage to someone who works less than that amount. But what I can say is that, given the experience in places like Massachusetts, where they've had a longer period of time operating it, you quickly lose that strategy, because you then have difficulty hiring somebody to fill that
talent pool, right?
Because the talent pool will go to where they get the health insurance coverage.
I would agree with that. I would agree with that wholeheartedly. And like I said, I see a lot of young people who are managing more than one job, and so they're working hard and they're working a lot of hours. They're working more than 4 hours a week, but not for any one employer that provides benefit coverage. And or
some of them may be starting a small business, doing other types of things.
Very entrepreneurial, and small businesses actually are the biggest employers in the United States. It's not major corporations. A lot of people are employed by businesses with under 50 people. Right. So these programs I see is a way to keep Virginia's economy healthy. The fact that we have all of these programs and services that say that no matter where you are in the big picture of Virginia's economy, we have something for you that keeps you healthy, keeps your family healthy. But when we get back from this next break, Senator Barker, we're going to be talking about Medicaid expansion, because if there has been one issue in Virginia that's been kicked around since Phil Puckett left us, all right, that's just me. But the one thing that's been kicked around is Medicaid expansion, and why Virginia just categorically refuses to consider it when so many states all around us have taken those benefits, including states that have Republican governors.
Many.
So once we get back from this break, we are going to cover Medicaid expansion, what it means for Virginia, and after the elections of November 7th, with a different set of people in our House of Delegates, whether or not we have an opportunity in Virginia to do something differently with Medicaid expansion. So please join us after the break.
Guess what? I have some news for you. There's free food right there, junk food. You see that truck? Oh, jeez. It's a 2 Michelin star chef. All for free, ladies and gentlemen. All for free.
Here we have a panzanella with summer vegetables and pesto. Enjoy. How we doing?
So what do you got going on underneath that plate there?
This food is really about to be thrown away.
Yeah.
Bro? Is there something wrong with this food? Where did you get it from?
From farmers markets. They put aside the ugly vegetables and the ugly fruits.
Carrot top, soft avocados. It was all food that was going to be discarded.
Even the drink you had is made from like a little bruised peach. Did it taste a little bruised?
Great. It's good.
The average person throws away 24 pounds of food a month.
That's a lot.
Isn't that a lot? Go visit SaveTheFood.com for more information. Thank you. Junk food time!
we're back to the Inside Scoop. Here again, your host.
Segment of Inside Scoop. I am your host, Catherine Reed, and we are talking about health care in Virginia tonight with Virginia Senator George Barker. Thank you so much again for your time. You have been a source of amazing information tonight, and so I want to wrap up this final segment talking about the future of Medicaid expansion in Virginia. So maybe we should start by helping our viewers to understand what Medicaid expansion is and how it differs from all the other things we've talked about tonight.
Right. When the Supreme Court upheld the Affordable Care Act as constitutional, they upheld all of it except for one segment of the law. And that was a provision that had been put in that said that every state had to expand its Medicaid program in a certain way or else pull out of the entire Medicaid program. And they said that was too coercive. So that became the one issue that states were in effect required to deal with as to how each state would approach it. And they could opt into the Medicaid expansion program or not. Most people think that if you're poor, you're covered by Medicaid. Now, you can be poor and covered by Medicaid if you're a child, up to 200% of poverty, or if you're pregnant, up to 200% of poverty, or if you're a parent of a young child, up to about 30% of the poverty level. However, if you are a parent, still well below the poverty level, at only 50% of the poverty level, you don't get no Medicaid coverage. If you are not a parent of a dependent child under the age of 18, it makes no difference whether you have any income, you don't get coverage for Medicaid. So there are a lot of people that the public, by and large, assumes are covered by Medicaid who aren't. So what was put into the law, and what each state now has to decide how to handle it, is to provide coverage up to 138% of poverty for all adults, or adults who are citizens and legal residents of the United States over a period of time. So that's what is Medicaid expansion, and each state got to make its own decision. The Medicaid expansion component of the Affordable Care Act went into effect on January 1 of 2014, so you could make your decision prior to that if you wanted to be participating in January 2014. We actually had a commission that was set up that had 5 House members and 5 Senate members to study it up front and to say what we should require before making that final decision to go forward with it. We set up a whole host of things and gave requirements to the Medicaid program to do it. The Medicaid program met every single one, and every single one early, not on time, not just on time, but even early. And but in the end, what we had a division between the Senate and the House. The Senate was supportive of Medicaid expansion. The House of Delegates was not supportive. And so, that was what then became the conundrum that had to be dealt with. In 2014, we in the Senate kept consistently passing Medicaid expansion, and we did it with all 20 Democrats and 3 Republicans doing that, but the House was not receptive. There appeared to be a path to get there, and at the last minute some things fell apart on that, and after a lengthy bullying session of a sort, the 3 Senate Republicans, one by one, agreed to go forward with the budget without the Medicaid expansion in there. They didn't really change it. They said they didn't change their position on Medicaid expansion. They still favored it. But however, 2 of those 3 are no longer in the Senate. They did not run for re-election in 2015. We still have, a majority in the Senate to be able to get us there. But one of the things that I've been saying all along, even after the fiasco that happened in 2014 where it did not go through, is that we will get Medicaid expansion. And I'm convinced that that is the case. And if anything, after November 7th, the prospects have improved. It's just sort of how we're going to get there, what types of concessions have to be made to get there, and there may be some modifications to what's in the program, but I'm convinced that we will get there and that we will get there within the next 2 years.
So in the time period that you're talking about after 2015, in the House it was 66 Republicans and 34 Democrats.
Right.
That has changed now. It's looking a lot like, with all the recounts, some of the recounts still up in the air, it's looking like 49-51, which isn't 66-34. And 15 seats held by Republicans are now filled with Democrats, 11 of them new women, I might add, which I'm very proud about. So I hope it does change the landscape, considering that there's very close numbers in the Senate. As you said, the Senate seems to consistently want Medicaid expansion. We've narrowed the gap in the House. So is this going to come down to sort of like face-saving measures where we call it some sort of waiver program or voucher program, or we call it something different so we get the program without it maybe being called Medicaid expansion? How do you see that rolling out so that we get what we want?
Well, I'll tell you what's happened in some other states, and a lot of that can give some indication of the types of things that might be considered here. There are various things that some states have incorporated when they were looking to do Medicaid expansion, and as you said, a lot of states that have Republican governors, some states that have Republican governors and Republican legislatures have moved in Medicaid expansion. So despite sort of the overall perspective on Capitol Hill, at the state level, it's not always been that partisan there. But some of them have done things like put in work requirements that someone had to at least be pursuing a job if they weren't working a job, but to be eligible for the Medicaid expansion. There may be some cost sharing types of things that could be put in there. For example, with the federally qualified health centers, the uninsured do pay when they come for a visit. So it's not necessarily out of the realm of out of the norm to expect that someone who actually has a little more income is going to be able to pay a portion of that. So there are a variety of things that can be done to help get us there.
What was interesting about John Kasich when he took Medicaid expansion in Ohio, because Ohio was like ground zero, I don't even know, 15 years ago for the beginning of the opioid epidemic. They had pill mills in the Ohio River Valley, and so one of the reasons John Kasich, my understanding is that he took Medicaid expansion was for rehabilitation programs because they got to their epidemic earlier than we did. In Virginia, you hear everything about opioid epidemics and what are we doing to stem the deaths and how we're meeting the needs of so many people being in crisis. But John Kasich had that problem earlier, recognized the problem earlier. They started doing things, passing legislation in Ohio to address these things earlier. Do you think in any way that people will see the need now that we are also in the throes of this opioid epidemic, this public health crisis, that Medicaid expansion is going to be an avenue to address that?
Well, actually, we had to meet the opioid crisis at the same time that the southeastern Ohio had it. Ours was concentrated mostly in Southwest Virginia initially.
That was the first case against Purdue Pharmaceuticals. U.S. District Attorney for the Western District successfully sued Purdue Pharmaceuticals, 2006.
So we've been dealing with the issue. We passed a lot of legislation to try to control it. We've actually been dramatically increased our success in being able to stop the pill mills and be able to deal with those physicians who were overprescribing, to be able to monitor them, to reduce the number of pills per person who gets that type of thing. So we've actually done a lot. What is interesting is that although the legislature in Virginia wasn't willing to do Medicaid expansion, I think mostly because it was called Medicaid expansion and
it was an ideological thing.
It was they weren't necessarily opposed to the program, they were just opposed to something that was called Medicaid expansion. At the same time, during the last 4 years, we have introduced two major new initiatives within our Medicaid program. One is provision of mental health, behavioral health services. And so we have a lot of people who previously didn't qualify for Medicaid, but because they have a chronic mental health problem, they are now covered by Medicaid and receiving those services.
That's right.
Similarly, just this past year, we implemented a program called ARTS, which is Addiction Rehabilitation and Treatment Services. And so it's targeted at substance abuse issues, including the opioid problem. And what we're now seeing in parts of Virginia in particular is a lot of people are not on opioids, but on heroin, which is actually more readily available in many instances. And it's cheaper.
And it's cheaper.
So, we've actually been able to do those types of things on a bipartisan basis. So I think, those do provide some some guidance that there may be ways to be able to use those types of things to help justify moving forward with Medicaid expansion in a holistic way.
Well, I'm glad to hear about the mental health services being kind of provided as part of this initiative, because I know that Creed Eads has been working for years to try to put money back into the mental health services program in Virginia. It seems to me it was, you would know better than I was, starved there for a period of years. And then the tragedy with his son suddenly made people ask, well, why don't we have enough beds and why don't we have an electronic bed registry? To your point, strides have been made, and maybe the public is not aware of the things that have happened behind the scenes to create more accessible mental health services and coverage for people who don't have private insurance. Yeah. But is this something that, you know, going forward, we can use these as avenues to get the General Assembly to embrace the idea that we should go a little bigger?
Well, certainly, I think that is part of the case, part of the way to make the case on these types of things. And I've been working on mental health issues ever since I got elected to the Assembly. And actually, when the tragedy occurred with Creed Eads and his son, I sort of took the lead, since he was supportive of these things, but he was having difficulty dealing with a lot of it, and sort of getting all the legislators who were involved together to come to consensus on the legislation that we passed in 2014, one of which was to set up the commission, which have been studying the issue for the last 4 years, and has 2 more years after this year to do it. We are making tremendous strides in progress in restructuring the system. And actually what we're doing now is moving forward with things such as putting more emphasis up front, so that if someone calls and said, I have a mental health problem and I need some help, you don't put them on a waiting list to do the evaluation a month from now. You see them today, or at the very latest tomorrow morning. And so you get them into the system immediately. That makes a huge difference in terms of getting people to start getting the services when they're willing to ask for them. Because a month from now they may say, I don't need them anymore.
Right.
And you know, that can make a long-term difference in terms of stabilizing those individuals. We also are improving the back end of things, so that we, the front end there and providing those services up front will mean there will be a lot fewer people who go into crisis and need to go into some type of inpatient setting or be detained in some way. On the back end, we have a lot of people in hospitals who may have needed to be there when they went in. They don't need to be there anymore, but they're still there because we don't have any place to put them back in the community. So we're dramatically increasing that as well. And I think by addressing both of those, we will, in the long term, save substantial amounts of money. And we have a whole restructuring plan that's been put forward now by the Commissioner of the Department of Behavioral Health to do that and just change the dynamics, change the incentives, change the processes that have created the problems in the past. That can help provide mental health services, save money, and help draw attention to the fact that a lot of people can benefit if we do something like Medicaid expansion.
Well, and I agree with you. And so the last thing I want to say besides thank you is the fact that people should get involved by keeping up with what the bills are. Our session starts January 10th, ends March 30th. There will be lots of bills.
March 10th.
March 10th. January 10th to March 10th. Right. And there'll be lots of bills. People should pay attention, and that one phone call, that one email, do they make a difference?
People listen, so I guarantee you, legislators listen, so particularly to their constituents. So.
Thank you so much, and thank you for joining us tonight.